I work at ACI. I have the privilege of looking at how an agency that has 120 people go out into the system and liaise with LHDs and see how they can do hips better, how they can do delirium better, and how they can do all sorts of different things better. I have been loitering with intent. I just hang around what these people are doing. I don't come with a schema. I don't come with a design. I just try to listen to what it is that's going on. And I just want to give you a brief overview of what I've learned over the last couple of years, almost 2 years that I've now been with ACI. And the main message really is that when people come in with evidence, what you see is services saying, well, what planet are you from? What language do you speak? And please identify yourself and, how are you going to ever fit in with what it is that we are doing here? And that was kind of the main kind of feedback that I saw services give to people from ACI coming in with tools and all sorts of plans. And it was only when there was a creative conversation created between the people working for ACI and the people working in the LHDs, and the LHD staff being able to give feedback to people working in ACI, and that creative conversation leading not just to uptake but to innovation of the guideline. People within the services saying, yes, but what we are already doing is this, and what you should also be thinking about is that, such that there was a feedback situation created between what services were doing, what ACI was hoping they would be doing, and what it is that services were going to do now in response, which wasn't at all necessarily a linear pathway. I looked in detail at 3 studies: the Quality in Acute Stroke Care project, the HIPS project, how can we do hip fracture care better, and the Delirium project, the Confused Hospitalized Older People project. 3 projects that ACI went in with, kind of regarding these projects as implementation projects. We are going to tell people, well, these are the best ways of doing this kind of work, and please go away and work with us on how to realize this. A kind of top-down approach to some extent. But people working at the front line for ACI know very well that as soon as they come in, there'll be all sorts of conversations about what is already going on, what staff understand or do not understand about project management, about getting sponsors on board, about communicating with colleagues, about getting stuff to filter through into the organisation and so forth. So there's all sorts of additional contextual, interpersonal and political work that goes on around these kinds of projects. I'll talk a little bit about the projects individually and then clarify what it is that distinguishes them. The stroke care project was essentially about getting nurses to act on these protocols: fever, sugar, swallow. I won't go into the detail, but this was essentially about creating adherence to when these stroke patients come in, to make sure that fever, sugar and swallow are looked at. The issue of patient management is a separate issue, and that was an interesting aspect of this particular implementation program. So the focus here was on adherence. With regards to the HIPS project, there were a number of foci. One was to get the surgeon to talk to the geriatrician, and that wasn't always easy. To get the nurses to practice optimal pain management, that was an issue. To make sure there wasn't unnecessary fasting, which was an organisational issue. To make sure that there was early mobilisation, there's an allied health issue, and how was it all coordinated with what everybody else was doing. And so this was really a multidisciplinary professional pathway. Kind of different from adhering to a treatment protocol for specific patients. This is broader. It involves different kinds of people. The Confused Hospitalized Older People project was different again. It was about adherence. We need to do these cognitive screens, etc. It was about multidisciplinary collaboration, yeah? But it was also about managing patients with delirium, and that was something that could happen anywhere in the service, predominantly, of course, in surgery and emergency, but other places too. And this created a very complex dimension to this particular project, particularly when what was revealed as the project was unfolding was that there were several staff saying, I'm just too scared of these patients, I don't want to get near them again, and I'm actually thinking of retiring. And families were saying things like, we feel that our loved ones are not looked after well enough, and sometimes things are happening that we don't agree with. And so this particular project raised all sorts of issues that could not have been, possibly not have been anticipated in advance, confronting ACI staff with all sorts of questions about how far we're going to push this thing, and confronting services with all sorts of tensions between, are we going to use pharmacology or restraints, or are we now going to adhere to the new guideline and try to communicate with these people and suss out what it is that we can do instead. If you put these projects on a line then, you realise that implementation isn't implementation isn't implementation. And these things are not necessarily knowable in advance. This kind of summarises the focus of these things. The aim of the QOSC was adherence, HIPS was about a multidisciplinary pathway, CHOPS was really about behaviour change on the part of the clinicians and how they behave with patients. This row that says context is to do with to what extent were these projects buoyed by developments that had already taken place within New South Wales around stroke care or hip fracture care or delirium. And particularly the first one was buoyed by a lot of work that had already happened. So again, implementation isn't implementation. There's a lot of stuff that goes on around these projects that influences the degree to which they take hold within the services where these things are targeted. In each of the three projects, there was high levels of staff and site variability. High levels of variability in staff knowledge about how to manage projects, as I said. High levels of variability in site practice. Wagga doing very different things from Port Macquarie, for example. Wagga having to worry about how Young was not yet up to speed with using nerve blocks, whereas Port Macquarie was already communicating with ambulance and communities about how to facilitate all sorts of processes that went well beyond what it was that the original key principles set out. So a very creative response on the part of Port Macquarie to what it was that goes on in the area of delirium care, whereas Wagga was still struggling to get on board with some issues that other sites were taking for granted. So again, when you go into different places with your implementation plans, there are very different responses possible, and these are the kinds of things that we need to take into account. So we can distinguish these projects then in terms of levels of complexity, whereas QOSC, that stroke project, was moderately complex. HIPS was medium complexity, but CHOPS was definitely very highly complex. Now, I'll get to the point of all of this in a second, but initially just to say that you can map this onto, if we look across healthcare more generally, you can identify some processes that are kind of standard and routinizable, others that are similar but not identical in how they unfold, and then there are the ones that are non-repetitive, that are highly complex at the other end. And I suppose what you could say then is that when you implement projects, you may end up at different ends of these, of the what they call the quality broom, that picture there at the bottom, where CHOPS was definitely operating at the end of the complex end of the broom. Now, the main learnings here then is that research translation is rarely a uniform change process, producing like responses and outcomes across participating sites. And I suppose it's important then also to recognise that sites do not necessarily fail when there's variability. It is just that they are acting in ways that are relevant and suitable to the kinds of things that are going on in those sites and with the people working there. The second thing there is the more complex the health service provision, the more complex research translation. I think it is unavoidable that, if you go into a complex setting that your designs will need to accommodate the kinds of complexities that you're encountering then to make sense of what it is that is going on there. And in that sense, it was interesting that Tony started up with translational research on his first slide and not research translation, because I think there is an interesting distinction to be made there, which I'll come back to at the end of my talk. Finally, the greater need for translation research to make sense of how frontline staff and patients adapt to research translation. Now, we need to really start looking more closely at the effects of people coming in with evidence and guidelines and models of care to see what it is that sites are doing in response, a bit like beginning to listen to patients about what they think is in fact important in their care, rather than stay focused on our evidence and the kinds of things that we find are important for people to take up. Now, I'd like to shift gears a little bit. At ACI, there's some money available for people to do research in implementation. And what we did was we looked at the proposals that we received last year to make sense of what it is that researchers find important when they try to do this kind of work, this kind of research in this domain. So how do researchers approach systems change? What we did was we said, well, let's ask, of all these proposals that we've received, there are about 30, what is studied, how is it approached, what are the outcomes that are sought, and what is the research stance? And there were kind of three main ways in which we could classify the proposals that came in. There was one bunch that focused on a treatment procedure, quite narrowly medically defined. And this was about testing a pre-designed solution or intervention, producing recommendations and leading to truth statements. This works or it doesn't work, or this is what people should be doing or using. There was some broadening out a little bit towards clinical process, where people might design or test a solution or an intervention. Their aims might be conversion into policy or practice. And this was more of an applied approach. It was people wanting to make sure that whatever they were doing was translating into something relevant for others, whether that was in policy or in practice. We got really only one proposal that looked at the system of care. And the system of care is not about a specific process, it's about looking at what goes on in situ. People sat down with stakeholders, researchers, but also consumers and clinicians, to co-design an intervention for what it is that they wanted to do. They sought the outcome of adaptive practice, not a change in practice, but adaptive practice meaning people with enough capacity and capability to know what it is that needed to change on an ongoing basis to keep up with changes that inevitably happen in a complex system. Very different attitude compared to researchers going in and saying this is what needs to happen, or even people saying, well, let's now produce a set of outcomes and impacts. This is an ongoing iterative thing, creating a feedback loop and creating capacity and capability, interweaving knowledge and local practice. Of course, most of the proposals that we received focused on treatments and clinical processes, and as I said, only one really focused on the system of care, on the more complex end of what goes on in healthcare. And of course, the complex end is the front line of care. This is where patients receive their care. This is where all these kind of different competing imperatives come in, and where people have to make sense of whether to run in that direction or in another direction. And what that means then is that while we're happy to operate in the standard and routine end of healthcare provision, we tend to leave the more complex aspects of what goes on there to our imagination. And then, if you go in and you look at what goes on, this is somewhere in a local hospital that won't be named. On an ordinary day with 4 patients in a corridor, people trying to squeeze in between beds and trying to make sense of what goes on with these patients. This is what goes on for frontline clinicians and patients. And this is the complex stuff that I think our research designs are not really looking at. And this is really what translational research can look at. If we come in with a handover protocol for ambulance officers to talk to emergency staff, can we ignore this? Well, we can't. We have to really take account of the kinds of circumstances within which these people work, and within which it should become possible or remain impossible for them to take up any suggestions about practice change. So I think our focus has been predominantly on research translation, which is we do come in with a set of ideas about what needs to happen and are expecting that to translate into a practice change that we can then go and measure. And yet, as we can see, we can tell from ACI and the work that goes on there, research translation is very unpredictable in practice. Sites are doing very different things in response to the initiatives that ACI conducts. But ACI also looks at the effects of what it does, and that we can call translational research. This is not about research translation. This is not about trying to get the hip fracture model of care to work in all the sites that are engaged in the initiative. This is about looking at what is it really that WAGA is doing in response to ACI arriving, and how can we now learn from what it is that these different sites are doing, and what can we do to enable them to better engage with these kinds of projects that are done in the name of practice improvement, to perhaps focus less on evidence and more on what it is that those people need to become better at even starting to think about research, research evidence and practice change. Translational research is a bottom-up orientation, and I was very pleased to see that on Tony's first slide. The title of your slide was Translational Research. And so it delves into how practices and practitioners adapt to research translation. What kinds of capacities do people need to even begin to engage with research translation? What kinds of things can they do in response? Is there a method for them to innovate the evidence that is presented to them? Not evidence-based practice, but practice-based evidence. To what extent are we actually focusing on the kinds of innovation and creativity that is present in sites? When someone arrives with an idea, they may have all sorts of other ideas or additional ideas to extend and expand what it is that is proposed. Unfortunately, though, and this is a funding issue, translational research is in its infancy, because we do favour projects that are structured to ensure that there's a particular answer that gets translated into what it is that people are doing, and there's not really enough space created for allowing frontline staff, patients, clinicians to articulate in their terms what it is that's important in response to, for example, the problem that we have around hip care or delirium care. Okay, thank you.